Great. Welcome, everybody. It is 6:01, and we do like to be on time. Thank you very much for joining us on a Thursday evening. We are very happy to welcome Dr. Kayembe here this evening, who is going to continue our clinical case review and going to focus a little bit on our knowledge of diabetes. Dr. Kay, shall I run the first poll now just to get us started?
About how confident they are about the guideline.
Yes, that one. Shall we do that?
Yes.
So what we're just going to open up with a poll. If the poll doesn't show on your screen, apologies. Sometimes if you've got an old version of Zoom, it doesn't. And this is just for us to find out a little bit how confident you are feeling in managing your patients with diabetes. So those for you that are watching this on webinar, you won't be able to see the questions. So just for your own sakes, our first question there, and you can also put answers in the chat, is how confident are you in applying the SEMSA guideline when you're managing a patient with type 2 diabetes? And please just click on that polls for us. There we go. We can see people are starting to answer. Question number 2 there is how confident you are on the steps of prescribing oral agents for type 2 diabetes. And then question number 3 is how confident are you in the initiating and managing of insulin in a patient that has type 2 diabetes. So just, yeah, we can see already of our participants, most of them has already participated.
We have already 7 out of 7.
Yes, there we go. Okay, good. You can see the poll as well. That's excellent.
Yes, I can see.
Great. I think we've
How
got...
long do we give them?
Yeah, it's up to you. I think we can end the poll now. We've got about...
You can end the poll now, and you can
yes.
comment on the poll, Dr. Muller.
Yes, so great. So we're now going to just share I'll share the results. Hopefully some of you would be able to see that. So firstly, in terms of how confident people are in managing type 2 diabetes, 67% of you feel you're partially confident, you know, some of it. Some of you feel that you're quite confident, but nobody feels very confident yet on those SEMSA 197-page guideline. And then there's 22% that's not very confident yet at all. In terms of our oral agents for type 2, there's a slightly more, people are more confident there. So 56% of people feel they can manage the oral medicines for type 2 diabetes, 33% partially confident, 11% would like a little bit more help with that. And then, yes, not quite so confident with insulin. So we can see partially confident, about 56% of people, 44% of people think they can manage the insulin prescription. And yes, so there's definitely some room for getting you guys very confident on managing those patients. I'm going to stop there and I'm going to hand over to Dr. Kay.
Okay. Do I close the poll? Okay. Good evening. Let's see. Okay. As we started last time, 2 weeks ago, this will remain true every time that we work, every patient, every prescription, every challenge, any outcome is an opportunity for us to learn, as you've seen, even through the poll. We will learn continuously. There is always one more thing to learn. So no matter how many times you will read the guideline, and no matter how many times you will be dealing with a particular patient, managing a particular disease, there is always something more to learn. And I will want to start by apologizing because all my animation are not up to scratch. I didn't really have enough time to finish all my slides the way I would have liked them to be. Just a recap, I think that all of us will remember the last time we met, one of the take-home message was dealing with hypoglycemia. We should not forget the rule of 15. by 15 if our patient is able to swallow. And we all remember those signs and the symptoms of hypoglycemia. So, if you were there last time, I think at the end we did conclude that our patient had hypoglycemia because there was an unrecognized dual sulfonyl therapy that the patient was on, because the patient was getting glimepiride from the public sector while also receiving at the same time gliclazide from the medical aid. So just to give you an idea how significant sulfonylurea or hypoglycemia is with sulfonylurea, we need to remember that it is common. But as you can see, it is not generally severe. And if we say that there was unrecognized dual therapy, I did put there on this slide the 3 most common sulfonylurea that we might encounter when we deal with our patient. Because basically, when we went through the file, we noticed that one of us could write that the patient was on both glimepiride and gliclazide. And despite the patient coming with recurrent severe anemia, couldn't identify that that prescription was not meant to be. So these are the 3 main sulfonylurea that you will find in our setting. The government, we have mainly glimepiride that comes, I think that if there are some pharmacists on the meeting, I think that it comes as a tablet of 1 milligram and a tablet of 2 milligram, but there are also tablets of 4 milligram. Gliclazide comes as MR, modified release tablet, and normal release tablet. And glibenclamide, as you can see, it is not bold because no one should be started today on glibenclamide, and whoever among our patients is still on glibenclamide should be taken off and move to either glimepiride or gliclazide, depending on the affordability. If the patient is in government, you can only move your patient from glibenclamide to glimepiride. But if the patient can afford or is on a medical aid, because despite us working in government, we have colleagues that are diabetic, that have the medical aid, that we can advise accordingly, and we should be able to prescribe gliclazide to them. So, but do we know? Because we need to move this patient from one drug to another one. How confident are we to be able to move them from one drug to another? I will ask Dr. Muller to put the poll about the equivalence in milligram when it comes to sulfonylurea. Dr. Muller, you can comment.
Right, yeah, so the poll is up there. So for those of you on webinar that might not be able to see it, question number 1 there is, what is the equivalent dose for 1 to 2 milligrams glimepiride? So your patient might be arriving on glibenclamide and you're going to switch him to glimepiride. So you need to know what that dosing is. And you've got 4 options there: glibenclamide 5 milligrams, glibenclamide 10, glibenclamide 15, or glibenclamide 20. Feel free to commit to an answer. We don't know who you are. Give it a try. And then our second question, what is the equivalent dose?
We won't mark you.
Yes. We're just going to see how the group does. And then the second question, what is the equivalent dose for 1 to 2 milligrams glimepiride? Again, and this time you've got gliclazide MR available. You've got a 10 milligram, a 20 milligram, a 30 milligram, a 40 milligram, or an 80 milligram option there. So if you're about to switch your patient over, they've come from private on their glycoside prescription, and you got to put them on glimepiride. And good, we've already got 38. Oh, people are thinking, they're not sure, they're not yet committing. We've got 38% that's answered so far. Oh, there we go. Another person brave. Come on, give it a guess. So even if you don't know, by wondering about it and by committing yourself to an answer, that actually helps us learn. So waking up the neural pathways of saying, okay, I'm going to guess that it's this. I've got no idea. Make a commitment. It will help you learn better once we give you the correct answer. Great. So yes, people are willing to commit there. We've got 70% is already answered. Excellent. We'll give it another 5 seconds and then we'll end the poll so we can see where we're at. Okay, great. So I'm going to end the poll here.
Okay.
And then let's share our results. So first question there, how much is the equivalent dose for 1 to 2 milligrams glimepiride? And 87% of people thought it was glibenclamide 5 milligrams, and 13% thought it was glibenclamide 10 milligrams. Dr. K, shall I look at the second answer as well? Because I'm sure you've got a slide on this.
Yes.
And then the second question there is the equivalent dose for in terms of glycoside. Yeah, people were not so sure. 67% thought glycoside MR 10 milligrams, 7% thought 20, 20% thought 40, and there's 7% that thought 80. So we've got quite a lot of variety here in terms of switching over patients from glycoside to glimepiride. I'm going to stop sharing there and hand back over to.
So what is, okay, the majority got the answer right when it comes to glimepiride and glibenclamide, and no one got it right when it comes to glimepiride 2. Okay, now there is 20%. At least one, no one got it right when it comes to glycoside MR, which is when you go through the same guideline again, that is the preferred sulfonylurea, remember. So it was worth us discussing this topic tonight. So just going, as you can see there, 1 to 2 milligrams of glimepiride gets you 30 milligrams of glycoside MR and 5 milligrams of glibenclamide. And in the case of our patient, remember our patient was getting both 6 milligrams of glimepiride and 60 milligrams of glycoside when she was going through those recurrent hypoglycemia. So when you put everything together and you want to convert to get in glimepiride how much total sulfonylurea that patient was getting, or in glycoside how much that patient was getting, basically this patient was getting 10 milligrams of glimepiride. That was almost the equivalent also of 240 milligrams of glycoside. So it was not a surprise that the patient was getting those severe hypoglycemia, because remember, remember, this is the correct dose that the patient was getting, 640 in glycoside, and the maximum that the patient needed to get when it comes to glimepiride, if we put everything together, was supposed to be 8 milligrams if you really push it. But we discussed last time that above 4 milligrams, there is really nothing that you get out of pushing glimepiride up. And the glycoside MR, the maximum that you can give to your patient is 120. But when you put everything together, the patient was getting way, way, way above what is required and what is safe for that patient. Just to give you an idea, so those are the main sulfonylurea that we will be facing, or we might see our patient coming with, or we might be putting our patient on. This is just for you to have an idea on how long the biologic effect take. Just again, whenever they come with hypo and you need to fight to get your patient admitted, as you can see, almost all of them get your patient to remain on effect through 24 hours. So it is impossible and it is unsafe that your patient should go home, especially in the rural area, or especially where it is difficult for the patient to return to the hospital, because that hypoglycemia is more likely to recur. These drugs take long to go away. So again, as you can see, if going back to our patient, most probably when you check those most likely situations that are prone to sending your patient in hypoglycemia, when they are on sulfonylurea, this patient was on too high medication dose. That is one of the reasons, that was the main reason why the patient was experiencing those severe hypoglycemia. And this is just to remind us again, when you compare sulfonylurea to other drugs, how common your patient on sulfonylurea are more likely to experience hypoglycemia. This is again another study that shows you that patient on sulfonylurea, when compared to patient on metformin, they are more likely 4 times, almost 5 times more likely to get hypoglycemia that require hospitalization compared to a patient that is on metformin. I'm bringing this up because there was a patient recently in the ward or in the department that got hypoglycemia. The patient was on sulfonylurea and the patient was on metformin. And unfortunately, the colleague chose to stop metformin rather than to stop sulfonylurea. So when your patient is on sulfonylurea and metformin and experience hypoglycemia until proven otherwise, the culprit should be sulfonylurea, not metformin. So the drug to stop or the drug to reduce will be sulfonylurea, not metformin. So now, you still remember the case? We ended up stopping one of the sulfonylurea. So this brings up, if you have to decide among, because the patient cannot get 2 sulfonylurea at the same time. If your patient is on both glimepiride and gliclazide, which one would you stop? And why would you choose to stop that? And this brings us to what is the preferred sulfonylurea. So if you had to stop sulfonylurea in this patient, the one that should be taken off should have been glimepiride, because you can read the guideline again. The preferred sulfonylurea is gliclazide, not glimepiride. And why is it that gliclazide MR is the preferred sulfonylurea? It's because consistently it has always been associated with lower rate of hypoglycemia, and it does have better cardiovascular and renal safety profile compared to any other sulfonylurea. And on top of that, it does have been proven to have benefit for long-term microvascular disease outcome. So this is just to tell us and to remind one another, yes, if the patient cannot have means to get glycoside, we will give that patient the one that is available to us in the public sector, glimepiride. But if your patient can afford, if your patient have a medical aid, comes to you in public sector and need sulfonylurea to control diabetes, please just make sure that you move that patient from glimepiride to glycoside. So this is just to show you hypoglycemia wise, when a patient is on glycoside, you get almost 50% fewer confirmed hypoglycemia compared to patients that are on glimepiride. And we all know that once patient experience hypoglycemia, they become so scared and adherence will always suffer. So if they can afford, if you can access glycoside, why don't you take a chance and put a patient on glimepiride, a drug that is more likely to lead your patient experiencing hypoglycemia. Another reason why glycoside is the preferred sulfonylurea, as you can see, using the data from the ACCORD trial, you will see that when a patient is on glycoside, there is a reduced progression of nephropathy, there is a prevention of nephropathy, and there is a reduction in the risk of end-stage renal disease. This is another reason why even the guideline advise that your patient, if in need of sulfonylurea, should be offered glycoside rather than any other sulfonylurea. And even at equal reduction of Hba1c, these protection, these benefit were not replicated with any other sulfonylurea. You might have taken the Hba1c down, but you will never get the benefit of renal primary prevention or progression or even a risk of end-stage renal disease or even regression with any other sulfonylurea rather than glycoside. So those are the things that we all need to know whenever we advise our patient that comes to us that have lost their medical aid. You need to know and discuss with them what they might be losing. And the one that still contemplates, they have a medical aid, but they are in public sector, they want to come to you and get care from you, you should be able to advise them, yes, you can continue, I will monitor you, but let me give you a prescription that you'll send to your medical aid because glycoside is not glimepiride and glimepiride is not glycoside. The other reason why glycoside is the preferred drug is that it is not only protecting the kidneys, but it is also safe in terms of kidney function. So as you can see, you might still use glycoside at severe or more severe degree of renal impairment than using glimepiride. For example, below 60, if you want to really be strict, it is not as green as with glimepiride as when your patient is on glycoside. So when your patient is on a glycoside, be it G1, G3, or G2, you just prescribe the treatment without worrying about the risk of hypoglycemia or adjusting the dose. But when it comes to glimepiride, you need to start watching out every time your patient eGFR drops below 60, you might need to consider reducing your patient glimepiride. So, but is it all doom when it comes to glimepiride? Because that is what we give to our patient. And so for those that comes to us, what do we need to know about glimepiride, and what our patient that receives glimepiride get from out of it? So it has been proven that glimepiride is quite proven or established safety when it comes to cardiovascular disease. This is, you can read about the data from the Carolina study. So it is safe because if you go back again and read about sulfonylurea, and one of the reasons, if some of the people who were treating diabetes maybe 10 years ago, you remember that we used to start patient, it was stated, you come, you are not obese, your first choice will be a sulfonylurea, and the first choice for obese patient will be metformin. But later on, because of what was seen to be increased cardiovascular risk linked to sulfonylurea, the data changed. That is why even up until now, metformin is now the first line treatment when it comes to initiating patient on oral therapy. So glimepiride is a quite cardiovascular safe drug that you get to your patient. So even if it causes more hypo than glycoside, it's not all bad. The second thing, that this is just to give you an idea on the differences between hypoglycemia caused by glycoside and hypoglycemia caused by glimepiride. In red, as you can see there, almost 6 times the hypoglycemia that are caused by glycoside, that is glibenclamide. That is one of the reasons why no one should keep a patient on glibenclamide. So, but sulfonylurea, as we say, glycoside lead to more glimepiride lead to more hypo than glycoside, but again, most of those hypos that are caused by glimepiride are not severe. And another thing that we need to remember as we talk to our patient, when it comes to Hba1c reduction, as you can see, the red and the orange, both glycoside and glimepiride are as effective in decreasing Hba1c. And we all know that primarily the benefit, the reduction of microvascular complication is linked to your patient Hba1c reduction. So even when, that is one of the reasons why the government is still using glimepiride. So it's not really a bad drug, but there are benefits that you get from glycoside that you will not get from glimepiride. So basically, our patient was on, after we stopped glimepiride, the patient remained on glycoside 60 milligram that was taken on a daily basis once. This takes us to the step-by-step when you go through the guideline. Which step do you expect your patient to be? Because now our patient here is only on glycoside monotherapy, while in fact, when you go through the guideline, the first step is metformin based, because the recommendation in every single guideline is that every single patient should be started on metformin at the time of diagnosis, in conjunction with comprehensive lifestyle modification that includes weight management, physical activity, self education, and and management, nutritional medical therapy. So you provide those non-pharmacological modalities to your patient, but you also put your patient on metformin. That is the first step. This is one of the issue with the treatment that you find out on this patient. Our patient was on glycoside alone, not on metformin. And the reason why metformin is the first line therapy is that it has been proven to be effective, it is safe, it is inexpensive, and it does also have the ability to reduce cardiovascular event and even death. That is why it is recommended that every single patient that is diagnosed with diabetes type 2, unless there are contraindication, should be on metformin. So metformin should be considered. The only exception is that you might have an additional drug to metformin, or you use something different, is when you have special circumstances. Today, for example, in 2022, when you have means, when you are in private and you want to start your patient, you diagnose your patient with diabetes type 2, some of the consideration will be, yes, you put your patient on metformin, but you need now to zoom in and find out, is my patient having heart failure, for example? There is a particular class of anti-diabetic drugs that you need to add to your patient, to metformin. Is your patient having chronic kidney disease? There is a particular 2 or different family of drugs that you need to pick a drug within and add to metformin. If you have a consideration about, is my patient at risk of having hypoglycemia, and you don't want to put your patient at that risk of hypoglycemia, you need to get your patient some of the new drugs on top of metformin. If you don't want, if your patient is obese or your patient is worried about gaining weight, because sulfonylurea, for example, will get your patient some kgs at the same way that insulin will do that. If you have a consideration about my patient, or your patient is worried about gaining weight or not gaining weight, there are some drugs that you will add on metformin. Or if your patient have a contraindication to metformin, in that case, you need to get something else to put your patient on. So, and we are all familiar with gastrointestinal intolerance. So if your patient cannot tolerate metformin, definitely it won't be a surprise that you might find a patient with a prescription for type 2 diabetes that doesn't contain metformin. We all know about these side effects. We need to teach our patient about this gastrointestinal intolerance, because if you overlook them, the patient will link them to the medication, they will not take them, and you will end up not achieving the Hba1c that you need for your patient to reduce those complications. So as we prescribe metformin, we need to discuss this issue with our patient, because once they have gastrointestinal intolerance, they might not be able to continue, and you need to look for an alternative drug. And we need to remember they are very common. Almost 1 in 3 patients, 1 in 5 to 1 in 3 patients might develop this side effect. It is not because they took metformin for 1 year. It's not because they took metformin for 6 months and they were not having side effect, and later on they come to you and complain about it. You should not dismiss. It can happen anytime while they are using metformin, and it can happen at any dose. 1 tablet can lead to gastrointestinal intolerance, and in some other patients, you need to get to the maximum for you to get intolerance. So we need to be mindful of those facts, because if you dismiss, your patient will dismiss your treatment. At the end of the day, you will be frustrated of getting a patient that doesn't achieve the target. And as you can see, up to 10% of our patients might end up discontinuing metformin because of gastrointestinal intolerance. So we cannot prescribe metformin and not care about the fact that they might, our patient might not tolerate the treatment. So what do you do to try to reduce this gastrointestinal intolerance? Those are things that we need to learn and practice. So as you start your patient on treatment, you should advise your patient to take metformin with food. It reduces the risk of gastrointestinal intolerance. You don't start with the maximum dose, you go slowly. You are more likely to reduce the risk for intolerance. If they do happen to get intolerance, give them metformin holiday. Just stopping metformin for a while and putting them back later can help them tolerate, even if you gave them the same dose that they once didn't tolerate. And particularly also following the holiday, if you further reduce the dose, you might get your patient tolerate metformin, because you better get your patient a little of metformin, because it is not solely about decreasing the blood glucose, but also the cardiovascular protection. And the other way of doing it, because we have a patient that can afford, we need to remember that there are formulation extended release or slow release of metformin that are there. By switching your patient from a normal release metformin to an extended or slow release metformin, you can reduce gastrointestinal intolerance. So our patient, just to share with you, who was only getting glycoside in November last year, it was because she never tolerated the 500 milligram of, oh, my internet. She never tolerated milligram of metformin. That was the reason why she was only on glycoside, on sulfonylurea. And these measures to try to mitigate those were never attempted. So what happened is that if you move your patient from the normal release to the extent, you can see the difference between diarrhea in normal release, it is close to 60%, while you cut it by 5 times when you give your patient an extended release. Same apply to nausea, same apply to epigastric pain, and as you can see, even abdominal pain. So it is important that we know that patient that comes If patient can afford to go buy it by themselves, prescribe extended release so that at least they still carry some metformin with them. Medical aid the release metformin. So they come, they don't tolerate, they tried work, you did reduce the dose, it didn't work, you gave them holiday, it didn't work, please try to switch them to extended the release, and they might, we just warn them, it might work, it might not work, but it is more likely to have less side effect, or side effects are less common with extended release. So this patient, for example, that never tolerated 500 milligram of normal release metformin is currently on 1 gram, 1000 milligram release, and she's happy and she never experienced any gastrointestinal intolerance. So it does work. It is as effective as the normal release. Don't lose anything by moving the patient to extended release. The other benefit is that it is convenient to be used, because this extended release is used once a day with the meal, which can improve adherence in any case. So when we put our patient on metformin, as we were talking, the only time that we might find ourselves not giving metformin as the line treatment, some of the contraindication that we need to keep in mind is the EGFR. You cannot prescribe metformin without knowing your patient. And you cannot even repeat, you should not repeat a prescription of metformin if your patient doesn't have in the file a EGFR that is younger 1 year. So every single year, if the kidney function is normal, every single patient on metformin should get a EGFR done. And when it drops below 30, we know that there is a contraindication. So if a patient has a EGFR that is less than 30, obviously you don't expect that patient to be on metformin. Those are some other predisposing factors, that those are mainly factors that can lead to the patient developing lactic acidosis on metformin. I hope that there are people that treated the HIV during the era of D4T that can appreciate that almost that got lactic acidosis came back from ICU. So you need really to be mindful of this fact. That's why people are so worried about how to repeat the risk of lactic acidosis when they prescribe metformin, because it is rare, but when it does happen, your patient will not survive most of the time. So you need to know all those risk factors for lactic acidosis. This is just one of the things that we tend to forget. A patient with irritable bowel syndrome should ideally not be given metformin. Or a patient with other chronic gastrointestinal disorder, you shouldn't, because the likelihood that they will not tolerate metformin is high. And if you persist, you will be prescribing a treatment that they will be throwing away, or a treatment that will be making them sick. So these are the other reason why metformin is still the first line, is that it doesn't have a benefit on Hba1c when you compare to sulfonylurea. So even if our patient was on sulfonylurea, you still need to know that by adding metformin to his regimen on using a formulation that is extended, you get a benefit of further decreasing Hba1c. You get the benefit of preventing your patient from further gaining weight on sulfonylurea, and you still reduce cardiovascular mortality. So now, just step by step, we all remember, if you want to start your patient on metformin, usually you start your patient with 500 milligram, isn't it? Every 2 weeks, not after 3 months again. Metformin should be adjusted every 2 weeks, not after 3 months, not after 2 years, unless your patient was controlled. You check your patient fasting blood, you need to increase your patient metformin until they get the side effect. That is the only time that you cannot go further up. This is the dose that most of our patients have that help them to reach the glycemic target. So it is 1,000. There is really no benefit, glycemic benefit when you, or hypoglycemic benefit when you go above 200. People will wonder, but do we prescribe 850 3 times a day? Yes, we prescribe 850 3 times a day. Patient, not because we get more out of metformin as a hypoglycemic effect, but we get there because that is the optimal dose for cardiovascular benefit. But this applies only in obese patients. Please don't give 550 to a lean patient that need metformin. You don't need to push to 850 3 times a day. And as we say, no patient on metformin should be prescribed a repeat without an annual check of eGFR. And whenever the kidney suffers, we need to remember that we might adjust, or we should adjust our patient metformin. We know that when the eGFR falls below 45, but it still remains above 30, the maximum that our patient can get is 1 gram per day. It means 500 twice a day. And the only limiting factor that we also need to remember is when the patient is HIV positive and is using the dolutegravir as part of the antiretroviral therapy, you cannot give more than 1,000 milligrams per day. So this will be our closing or our last slide. Although metformin is the first line therapy for most of the patients when they are diagnosed with diabetes in the absence of contraindication, it is not always monotherapy. We will see as we go forward that there will be patients that will be started, who should be started on both metformin and the insulin. We'll discuss those indications later on. And we need also to remember, as a take-home message, is that every time, because every single patient that is diagnosed with type 2 diabetes should get a baseline Hba1c. So every time your patient has a Hba1c that is above 9 but below 10, or a Hba1c that is 1.5% above the target, because the target is individualized, that patient should not be on, but you rather start that patient on both metformin and sulfonylurea. The other time that you need also to start your metformin, not as a monotherapy, is when you have a patient with symptoms. If you have a catabolic patient, or if you have a patient that's peeing, drinking a lot, that lost weight, that is not willing to take insulin, metformin will never take care of symptom. That patient needs to be offered both metformin and sulfonylurea as initial treatment. Thank you very much.
Well, thank you very much. Certainly now we have taken our little bits of knowledge on these drugs to a whole nother level. That was great, Dr. Kay. I would love to hear if anybody has any questions. Please put them in the chat, or you can put your hand up, or you can just unmute if you'd like to ask a question. I'm also going to launch a little poll just to give us some feedback on how you guys have found the session. And we're also asking some questions about times and days to help us plan in the future. So there's a little poll that I've just put up there asking about how useful you found the presentation and the quality of the presentation, as well as times and dates that will suit you. Please do participate in that. But yes, are there any questions? Please put on the poll, put on the chat for us, or unmute yourself. There we go. People are starting to answer our poll. Thank you very much. Excellent. And they're
Tell
great.
them that I'm not seeing the poll.
Mrs. Mpinda, Dr. Mpinda, please just unmute yourself and then you can ask your question.
Thank you very much, Dr. Kay. The presentation was very good. I just have a question. Would you please comment on metformin holiday and how is it applicable in our context when you are willing to run away from side effect, from gastroenteritis side effect?
Okay. So basically, you've started your patient on metformin, and you did educate your patient about the possibility that these risks or those side effects might occur. Your patient comes back and reports them to you, or whenever you were reviewing your patient tells you that acknowledge having those side effects, and they are worried and they are not willing to carry on taking metformin. So what you do, you will stop metformin, but you will replace it, like, let's say, with insulin, or you will replace it with sulfonylurea. And tell the patient, remember, it does happen, we know it can happen, but there are tricks that are available that we can use to make your body tolerate metformin, because there is more to metformin than just reducing the blood glucose. So you pause metformin for a period of time. It is also like when your patient has a recurrent hypoglycemia, for example, and they've lost awareness. What they will tell you is that cut the treatment so that they go into hyper, so that they reset the clock, and they will be able to recognize hypoglycemia later on. So you just stop the treatment, but you would have replaced the treatment with something else in the meantime. And later on, you try again to put the patient it's like TB. You stop the treatment, you allow the liver to recover, and you rechallenge. Same apply, you stop metformin, you get the body to forget about it for a period of time, and then later on you rechallenge. Again, remember, like in DILI, you can rechallenge full dose, the patient fail, then you pause again, then you go gradually. So you can also stop metformin for a period of time, then put exactly the same dose that the patient was on it. If the patient happened not to tolerate, you pause again, because you would have discussed already with your patient the possibility that it might work or not work, If it doesn't work, we will start with a lower dose and see, and we'll stop to whatever dose your body tolerates. That's what you do with your patient.
Thank you very much. That was a very practical question. It's one of those, that's what's so great about these presentations. It gets into the little nitty-gritty questions one has when one is seeing patients. I'm just checking if there's any last questions. Thank you very much. I'm going to end the poll at this point. And we can see again, this presentation was seen to be very useful, an excellent presentation as usual. Dr. K, in terms of feedback, it does look like Thursday nights are the most popular, with Wednesday as a second choice. And the timing, it looks like the 6 o'clock is also the favorite choice. And if one was to move it later, would be better than earlier, but it does look like the 6 o'clock suits most people. And then as usual, we will certainly be taking this onto YouTube. So the recording will be put on YouTube for people who weren't able to attend this evening. So you'll be able to share with colleagues. And if you wanted to go over some of those things again. There doesn't seem to be any hands or any last comments from you, Dr. Kabengele?
No, I'm just grateful that the colleagues took their time to spend with us. And I think that those, as we say, there is always something to learn. And
and we've just lost the sound there.
Hello?
We just lost your last sentence, but the rest of the
No, I'm just saying
perfect.
that I hope that okay, my internet is playing me again. It is back. So I'm just grateful, and would like to thank everyone that came and that participated.
Wonderful. Have a lovely evening, and we will let you guys know when the next ones are happening. Good night, everybody.
Bye.